So I come from a center where we were using a lot of stents. This is the orange line. It went through the roof, disproportionate at some point. So we work really hard together, all the team, to make it more reasonable, to use stents wisely. The problem that we have interventional cardiologists is that we are very proactive. We don't like observation. We have a tool on the shelf and we use it, and we tend to overuse it. But observation is really important in research. It's what we need to do. We need to contemplate. We need to think to understand what's happening. We want to advance like this, like everything is advancing from one day to the next, but in fact, we advance like this. And this is what happened with DEs. In the beginning, we were really happy. We improved the outcomes. Then we started to use too many DEs, and we have some declining outcomes. And then DCBs arrived, and they might be the solution. But we first used in ISR, and it worked. And then we are saying in a small vessel looks to work pretty well. And now we are trying to use it in all comers. So we are sliding towards it without all the evidence, and this is how probably we are falling in that direction. So what we want in our institution at least is to explore DCB. It's a useful tool, but we want to understand how it works. So we are having two trials. The first one that I'm presenting today is the the Paris study, where we use the PREVAIL in all comers, acute and chronic coronary syndromes, and this is sponsored by MEDTRONIC. So we use the PREVAIL. And we have a very important group that is the high bleeding risk group, which is where patients might probably benefit more from this new strategy with DCBs. And I won't talk a lot about the Copernican trial, but it's covering the other setting, the STEMI patient, the one which is out of this setting. And this is investigator-initiated, not sponsored. So I will say a few words at the end about this study, because I know it's more controversial. The Paris study includes more than 20 centers in Europe. We started already more than 1 year ago. So we don't have final results yet, but I will share with you some information. These are some of the institutions that participate. When deciding which balloon, which DCB we were going to use, it was difficult, of course. We know this phrase, not all DCBs are created equal, so we were inspired by some of the investigators that are here, like Asim, with some publications where the PREVAIL seem to be having very promising results, higher dose of drugs, although we don't know in vivo what is the true dose in the vessel wall. But for this reason, we chose this balloon. Small vessel, we consider up to 3 millimeters, which is probably more intermediate. In this high bleeding group, we decided to do short DAPT, only 1 week, and single antiplatelet was allowed with ticagrelor. And also, we estimated the sample size in more than 500 patients. So the inclusion criteria basically are all comers, and a high bleeding risk was defined as a perceived DAPT score of more than 25, or concomitant anticoagulation. And we excluded ISR because we think that there is a lot of investigation in there, some investigation ongoing, so we wanted to focus in the other kind of patients. And we are not doing angiographic follow-up, but we are trying to understand with the baseline angio the predictors of failure of the DCB, also with some tools that allow us to understand the speed of the flow, not just the TIMI3, as Professor Service was mentioning yesterday. The primary endpoint is clinical, as I said, cardiac death, myocardial infarction, or new revascularization. And as I said, dual antiplatelet is recommended for 1 week in the high bleeding risk, but ticagrelor alone is also allowed. And right now we have more than 300 patients for the 500 that is the target. I'm not going to share the full population, but I just want to share a few data of the patients in Valladolid, in my hospital, which is the top recruiter because we started the first. We see that high bleeding risk patients are most of the patients that we are including here. So many patients that are anticoagulated or with other risk factors lie in this group. So this is very relevant clinically. But when we see the bleeding events in the follow-up, they are very similar in the high bleeding risk and no high bleeding risk group, which suggests that the DCB benefit for the bleeding events might be relevant in all the groups of patients. And what about death? What about the hard endpoint? Well, we have 1 case of acute occlusion in our institution and 1 sudden death at home that is potentially another acute occlusion. And yesterday I was hearing Hector saying, what about acute thrombosis? We don't talk anymore about acute thrombosis. This is one of the main targets.
It's the discussion.
Yeah.
I think we don't want to see this. I think we are kind of overlooking this issue, but I was triggered by the Candice conclusion. The first statement is trivial grade 3, no late thrombosis, no lesion thrombosis. But there are thrombosis in the prevail grade 3 at the scar. So I think it's important to restart to become more transparent in this.
I think so as well, and I triggered you with this photo and it worked perfectly. So thank you, Hector. And I just want to share a case because we have many cases very interesting. This was a 71-year-old male, prior stents in other vessels, diabetes mellitus, hypertension. He had a solved bladder cancer, so no bleeding, so it's not in the category of high bleeding risk, but we know what happens with these patients, a normal ejection fraction. So we checked, the stents were okay, but the LAD have several moderate stenosis all along, so the patient was very symptomatic. We decided to do pressure wire, and this is a diffuse disease, as you can see, that is 0.69, so significant. We did also OCT, where we saw some tight stenosis at several levels, and we decided to proceed with the patient included in the Paris study. We pre-dilated distally and more proximally with a 1-to-1 balloon, and then we implanted, we dilated with 3 DCBs all along the vessel. And the result angiographically was adequate. I mean, probably some dissections there. Physiologically, because we have the wire in place, the FFR went from 0.69 to 0.80, and no decrease along the vessel. And also same finding by QFR from 0.68 to 0.82. And by OCT, we see some type C dissections at several levels. Here we can see that. But the dilatation of the vessel was okay, the MLA was correct. So we stopped. But 4 weeks later, the patient that was on DAPT with ticagrelor started with hematuria, so they have to do some endoscopic treatment, and the DAPT has to be stopped, only monotherapy was continued afterwards, and the patient remained stable, asymptomatic, but 6 months post-PCI, the patient had a new angina, so we checked what happened. And what you see is that there is a severe lesion proximal to the stent in the circumflex, but the LAD, at least angiographically, looks good. So there is no, as I said, angiographic follow-up, but we have the chance to do it in this patient. So we did physiology again. FFR was 0.82. This is the OCT at follow-up. You can see that very distally there was still a small dissection, but the rest of the vessel has correctly healed, and the MLA was appropriate at all levels. And this is the drop of pressure in the circumflex, where, of course, we see it very clear edge restenosis in the circumflex. So we have to dilate that, score in balloon, and then we decided to use again Prevail 3.5 at this level, which was ostial circumflex, with a very nice result, normalization of the physiology, and a very good result also by OCT. So the patient is now 1 year post-PCI, he's active, he's asymptomatic, he has not bled anymore. And just one word about the Copernican trial. This is my last slide. My good friend Jorge Sant is the co-PI of this study, which is in STEMI patients randomized into stent or reduced stent strategy, which means that we only stay with DCB if the result is good. If not, we got put a stent, and that's not a crossover. Luckily, because we don't have sponsorship from industry, we got a grant from the European Union, an EFFECT trial grant, and we are involving now centers also in Italy and France, and we will perform, apart from a clinical investigation, cost effectiveness investigation to understand if the DCBs in STEMI patients really have to play a role in the future. Thank you very much.